Hey guys, so today we're really lucky. We get to sit with who has become recently one of my more favorite people, Dr. Matt Rome of Equilibrium Physical Therapy in New York City. Hi, Dr. Matt, how are you?
Hey, nice to be here. Pleasure to be here. This is a fun opportunity and looking forward to sharing some thoughts with you guys.
And I must admit, my background is a little bit more exciting than yours. So I think already we're off to a good start, at least for me.
Yes. Well, it is actually about 86 degrees in New York City today, so I can't complain about that, although I'm not sitting in a tree canopy in Costa Rica, so slightly something a little bit more to strive for, I guess.
Well, I am really appreciative of you making the time, and we actually got to this point because I came in to see you about 2 weeks ago with some issues that have been bothering me for a number of months, and I think it would be helpful if maybe you could just share a little bit of your background and what your practice is and what you guys specialize in. And then, I'd love to get into some of the details about advice that you offer to people in general about feeling their best every day. And then when issues do arise, how do we do our best to mitigate the effects of those issues? So maybe you'll share with us a little bit about your background and what your practice is.
Yeah, absolutely. So I always like to start out with explaining a little bit about the physical therapy field, because it's kind of it's become a little bit ambiguous as to what physical therapy is and the difference between the medical side and the wellness side. And then there's so many different styles of practice as well. So Equilibrium Physical Therapy in New York City, this is my practice I founded about 7 years ago, is founded more upon the individualized personal attention. So traditionally, as insurance companies are fighting us with declining reimbursement rates, a lot of physical therapy practices are gravitating toward higher volume models where it's a big open room with lots of tables, and a physical therapist will see you for 20 minutes and then pass you along to a technician or an aide to carry out the remainder of your treatment. So what Equilibrium is more of a boutique style studio where the treatment, we have open studios and a nice custom built out setting, but also private rooms with high-low tables, board certified clinicians where we spend an hour with you one-on-one. So whenever someone's looking to optimize performance, really get a good clinical eye on their body, one of the most important things besides having an educated clinician is having someone who's going to spend the time and pay proper attention to you. So that's how we founded our model of physical therapy in New York City. And then moving on from that is just making sure that you get good clinicians who specialize in niche areas that are going to be most specific to the reason why you are coming in, whether that's a stenosis or arthritic issue in the spine, arthritis in the hip or shoulder, a tendinopathy, a recurrent chronic condition versus an acute traumatic issue. So we have board certified specialists. There's 9 of them now by the APTA. So you can get sports, pediatric, geriatric, orthopedic, electrophysiologic. There's a lot of different board specialties now. So making sure you get a very qualified physical therapist to pair with your specific needs is really key. So kind of that's the background where my practice is founded.
And it's interesting to me because even as a layman, when I hear the term physiotherapist, can you just give us a little bit of detail about what does that actually mean? How is that different than other doctors we might go see?
Yeah, so it's a great question because it's changing now. With the emergence of new laws, we have what we call direct access laws, where physical therapists or physiotherapists are now primary care providers for the neuromusculoskeletal setting. So what that means is that you can come see a physical therapist in most states without a physician's prescription. And we are specialists in the neuromusculoskeletal field. So we're not going to prescribe medication. We're not going to order imaging for you, but we can rule in or rule out cases that may require imaging, and we'll set you up with the physician who can order the imaging that we would request of them. But oftentimes we can diagnose a pathology and keep you in-house in the clinic without the need to go to other specialists, get unnecessary medical tests when they're not not really needed. So the physical therapy setting is now can be used as your first point of contact into the medical industry, which is a great development within the field. So that's, whether it's any muscular pain, neurological pain, shoulders, hips, knee, ankle, a skeletal malalignment issue, a muscle imbalance issue, whether there's pain, or if you're looking just to look at your skeleton and optimize performance based on understanding your body and how you move.
So it's interesting. I mean, obviously I'm a big advocate of trying to start early to stay as healthy as you can for as long as you can. And, one of the most common things that I think people experience is obviously pain or discomfort within joints or muscles. And all too often it seems like there is a resort there, which is good to hear that it's changing, to either go to prescriptions or to even procedures, which seems to me just to be kind of the easiest thing, right? And, one of the things that you and I had a great conversation about is this idea of adherence, right? So when I come see Dr. Matt, and for instance, my issue was, I think we had three, but my biggest issue was my left shoulder, right? And in my labrum in particular. And you showed me a whole series of different exercises and things that I should be doing to strengthen it, to improve it. But as with all things, if I don't do it and adhere to the protocol that you suggest, then, which takes time, right? So I guess I'm curious to hear from you on that perspective is when people come in and they have a specific ailment, like my shoulder, for instance, and you're offering them some sort of protocol to support that ailment, what are some of the biggest hurdles that you see with your patients in terms of actually getting better?
Yeah, I mean, and you nailed it. Adherence and compliance is a huge one. So we drill that home on day one. Education, we provide really specific, detailed information on how you need to continue your therapy at home, provide video resources, print out resources. We always change and manipulate your home program, but the idea is to keep it as simple as possible to assist with adherence, because just like anything in the medical world, it's what we call a lifestyle change. And I remember back in grad school, we did these things called lifestyle change projects. It was basically learning how, if you're gonna advise someone to do an exercise or take a supplement or to change any type of their behavior that is gonna affect their daily routine, you need to experience what that feels like. Because it does take some work. Sometimes things are less challenging than others. Sometimes it's a simple one or 2 minute thing a day, but sometimes it's longer. And that's a really important thing in therapy. And a lot of the time we talk about the difference between active and passive therapy. So people often come into my office, they want just passive therapy, and we provide that. We provide joint manipulations, mobilizations, a lot of stretching, nerve glides. But the most important part is the assistance from the patient at home to take what we teach them, because they're not coming into physical therapy 5 to 7 days a week. We'll see them once a week, twice a week, sometimes 3 times a week. But most of the time it's at 1 to twice a week. You need to supplement that with a good educated home program. And so adherence is definitely key. Yeah.
And I think that's interesting because it requires, and this is maybe a broader conversation, but it does require that lifestyle change, which in particular, at least I've noticed in myself, even as I've gotten older, changing certain habits gets harder, and adopting new things and adding new things to my regimen and removing things. It's just an additional thing that takes us out of our routine to create hopefully a better one, but another thing to consider. What I would love to do, if it's okay with you, is I've been dying to ask you this question, which is I've seen your office. I mean, you see a lot of people on a daily basis, from ultra marathoners and top athletes all the way through to people who are aging. And I'm curious to know, maybe 1 or 2 of the most common things that you see happen with people's bodies as they age, and some of your suggestions towards how we can start earlier to mitigate those issues.
Yeah, I love that question, because the physical therapy field is now kind of being bombarded with all these other types of practices that are focused more on the wellness side and collaborating wellness with rehab. And the preventative medicine field is fantastic. And it's not just something that you can do to prevent injury, but it's taking those steps that understanding what type of injuries you're actually prone or susceptible to, and then preventing them. So you're not just jumping in blindly and say, I need to do this to prevent this. It's like, you know, you look at your body type. And so one of the big things that I see all the time are, you know, really happen from the ground up or the top down. And you want to look at the body type to understand that. What I mean by that is that understanding your skeletal alignment is so incredibly important. And this is important before you have pathology, before you have injury, before you have degenerative changes in your spine, your hip, whatnot, your knees. So basically everybody has a different body type, right? They have a different skeleton, they have a different spinal structure, their hips attach in the socket different ways. You could either be what's called anteverted or retroverted. That can cause a toe in or toe out. Your tibias, your lower legs can bow in, bow out. The way that your foot hits the ground, you could what we call pronate or supinate. And then on top of that, there's other sorts of compensatory practices and strategies that your body takes in order to deal with the alignment that you have. So are you hypomobile, where you have restricted motion, or are you hypermobile and you have excessive motion? So you could have one body type, but be stiff and not compensate, or you could have the exact same body type and actually be very mobile, and you can compensate in different ways. Every single pattern leads to a different stress on a bony structure, a soft tissue structure. So even though you don't have pain, even though you don't have injury, when you look at a skeletal alignment, you can see what type of injuries you're susceptible to. So what I advocate for a lot of my performance patients who are looking to optimize performance, prevent injury, is doing a full, what we call lower quarter skeletal malalignment exam. And then if necessary, we can fabricate orthotics. And you don't necessarily need something so aggressive, but if we can identify your foot and say, hey, you're landing on you're walking on the outside of your foot, called a supinator. You're not attenuating force by what we call having that arch collapse, that medial longitudinal arch. And then you really need some help attenuating force, because that force is shocking up right through the side of your leg, side of your foot, up into your hip, and can affect your alignment and your spine as well. So that in that type of situation, we want to provide a more compliant surface under their foot, like a cork or a leather or foam. Conversely, if you're having a very floppy type of pronatory foot, your arch is collapsing, your knees are coming inward, what we call a valgus stress at your knees. It can cause a lot of knee arthritis on the outside of your knees, ligament distress on the inside. So then we want to use something, a firm support like a graphite or a plastic, to support the integrity of the arch. So these are just simple ways to prevent further injury by understanding your specific body type.
I think to me it's particularly interesting because I'm not a doctor. I wasn't trained like this, and for people that have kind of been following along with our story, to me it always comes down to, as a patient, more often than not the expert, is it logical? Is what the practitioner is saying to me, is it logical? And what you're saying makes complete sense. If how my foot strikes the ground every time I walk, every time I run, is not exactly perfect for how the rest of my body is structured, eventually over time it's going to result in some sort of issue. So building ground up to support that process for the downstream effects of a collapsed arch or whatever it might be is it makes a ton of sense. So it kind of beckons the second question to me, which is just purely out of curiosity, as people age, where do you tend to see the most amount of issues? Like, as we hit our 30s and 40s, is it from there, does it go up? Is it like start with our knees, and then as we hit our 50s and 60s, does it move to our hips, and our 60s and 70s move to our back? Or is it really just different to everybody based on, like you're talking about, the fact that all of our variables are different?
Yeah, I mean, it is different for everybody. Variables are always different. I mean, there are your patterns. Low back pain is one of the most common issues in the world. It's kind of inevitable at some point in your life that you may experience some low back pain, but still understanding why you have that low back pain is important. There's a lot of different things that can cause low back pain. Once you start getting into your 30s and early 40s, is the first, a lot of time people feel that they're aging. Sometimes it hits you in your 20s. Sometimes people can make it to their 50s, but usually it's around that 30s where people are feeling a little of the aches and pains a little bit. But just understanding that, to check things out and get things evaluated. Usually at that point in your life, there's not really significant progressive arthritic change. So often issues in the back could be more what we call discogenic, or disc injuries. You can have nerve root compression from a disc injury. There are some anomalies where you can develop early arthritis. There's some instability issues. We call them spondylolisthesis, or a slippage of the spine in the back. So you can actually have a lot of these things at a young age. They're more common as we age. But I would say back pain is the one to really look out for. When you get into your 30s and 40s, and understanding how to prevent that as best as possible, and keeping your core strong, keeping your lower back strong, and again, understanding your alignment and your postural preferences are really important. And then again, knees are a big one. We walk a lot. The way that we've evolved is now walking on pavement and hard ground. We weren't always doing that, in our history. So a lot of that increases what we'll call the ground reaction forces up through our body. And so we get a lot more compressive wear on the knees. We get arthritic change in the knees. One of the most common knee issues I see is not necessarily actually arthritis of the main tibiofemoral joint. You could sit the tibia on the femur like that. You could have arthritis either on the inside or the outside of that joint. We see a ton of what we call patellofemoral pain syndrome. And the syndrome is a catch-all. It's not a true diagnosis. The syndrome is a combination of a bunch of symptoms. And so truthfully, patellofemoral pain syndrome can come from a lot of different types of issues, whether it's a tight IT band pulling the patella, but ultimately you can get some arthritic wear behind the kneecap. You can get some soft tissue inflammation, some fat pad inflammation underneath the kneecap. But that's probably one of the most common things that we see as we get into the 30s, is just generalized pain underneath the knee. And there's a lot we can do from that, from understanding your alignment and treating you in a physical therapy, getting you on a good plan.
And this brings up so many questions for me, and I know that we don't have all day with you, but there's a few more I'd like to get in, which is, so, okay, got that. And it sounds as though really the most effective way to understand what's going on in our own bodies, really the only way to understand, as there's no catch-all, is to come see an expert like you who can help us understand better what's happening and start looking preventatively and say, well, gee, if your foot is collapsed, your arch is collapsed, you might not be having this issue now, but patterns would recommend that this might be your next issue and this is what we can do. The first question that it kind of brings up is, as you think about fitness and physical activity, one of the things that I constantly hear from people, and there's actually a person in my life who's going through this now, who has opted to go through a procedure, which my opinion is that he's way too young. He's way too physically active and fit to do this, but he's opted for a procedure. Are there particular physical exercises that you see have far reduced risk of exacerbating potential issues? And are there exercises that you feel are on the higher risk spectrum? And not to go too much into detail, but just curious, like, if I'm going to work out what's the lowest impact thing I can do, and then what is something on the other end of the spectrum that might be high impact?
Yeah, well, that's an incredibly loaded question because, of course, it has to be so specific to you, and to say something that could exacerbate someone's condition may not exacerbate someone else's condition, and someone else's peak, in terms of pushing them to the limit may not be as challenging for others. But I would say if there is pathology, then you need to take that into account in terms of how you're prescribing a program. If we're taking a healthy person with no pain, no pathology, then there's a lot of different ways that you can really push someone aggressively. And it's also, it maybe not the answer you want here, but I would say one of the best ways to push someone as hard as they can is to find something that they enjoy. So whether that's, for some people it's Olympic lifting, CrossFit, swimming, some people hate free weights and they like body supported training, which can be extremely challenging. It's a lot of, these pull-ups and these dips and these body weight supported exercise, which I love. I do a lot of that in the clinic. So really finding a way to challenge someone and within a program that they enjoy is the best type of exercise. In terms of what not to do, just make sure you get someone who teaches you proper form and technique, because watching some videos online doesn't always get there. You know, you can watch some videos online and know what to do, but then you still do it wrong. Having someone in there with providing verbal cues, tactile cues, making sure you're contracting correctly and you're keeping the right position and posture is really, really important. So I see a lot of people when I'm in the gym doing these floppy core exercises. They're not contracting their what we call transverse abdominis, their core correctly. They're not in that neutral spine position, or, you know, and they're not, it's kind of a waste of time. So making sure you do everything correctly is, I'd say, the most important way to challenge yourself.
One of the things that's so interesting to me, again, as the patient and outside observer in all of this, is that there are a couple of through lines that seem to always be true, which is one, doing the right things correctly generally means you have to do less of the things to achieve the outcome that you want. And it dramatically reduces the potential risk associated with those things. And it's just interesting to me because it is, I think, become part of our culture that better, faster, cheaper is an approach that we like to take. And it makes sense, right? Like if I can wake up in the morning and I got a pain and I just, you know, take a couple of pills, you know, even though they might be causing other issues, that's something that, you know, people tend to gear towards. Like, oh, it's easy, I can do it, no problem. So I want to switch gears here for another second, because I do feel like we could talk about a lot of things for a long time, but I'm particularly interested, and this might be another loaded question, but procedures to me are something that should be taken with great consideration. And not to say that they are always wrong, because that's definitely not true. In many cases, I'm sure, and with a great practitioner, they'll tell you when it's needed. But is there a general rule of thumb or a way that you look at and say, well, once somebody has gone beyond a certain point, that, like, is it a pain threshold? Is it a mobility threshold? The combination of them? But like, at what point is it you're beyond the point at which we can try to pull you back, where a procedure is the only way to move forward? And the reason that I ask this is because, to me, I love Western medicine. I love all of the advances, but there are increased risks even with just going under general anesthesia that I don't think everyone fully internalizes before going into a procedure. And to that same note, it feels often that people say, well, I'm too far gone. So I'm curious to know kind of if there is some sense there or not really.
No, I really do love that question, because we get that all the time in the rehab setting. People are just coming to us and all they want to hear from us is you don't need surgery or don't need this procedure. And I love to say, I love to affirm that and reinforce that if possible. But the truth is, it's a combination of a variety of things. It's a decision that should be made with your physical therapist, with your physiatrist, which is more of a rehab sports medicine doctor that's non-surgical, and of course an orthopedist or whatever specialty you're going to see or considering a procedure for. The most important thing is that we don't rely specifically on imaging. You know, and imaging can show one thing, you know, but if it doesn't correspond with true in the clinic pathology or in the clinic pain, that's the issue. So you can have, if we take an MRI of 100 people with zero low back pain who are in between the age of 40 and 50, you're probably going to see some disc herniations. You're going to see some mild degenerative conditions. You're going to see some beginning of what we call stenosis. So if that person is not having pain, they don't need a procedure, even if they see pathology on radiographs or MR imaging. So understanding how to don't simply rely on an image. It's how you're presenting clinically, and then also understanding what are your other options. And so there's been a big movement, but now over the past, say, 5 years, it's really grown is regenerative medicine, regenerative therapy. And so stem cell injections, platelet-rich plasma, PRP injections. A lot of these things aren't covered by insurance, but they have the clinical efficacy around them is emerging, and that's going to help eventually reimbursements for them. But right now, instead of just jumping right to a steroid injection, you know, there's and a surgical procedure, there's some other options to consider. So seeing a really good physiatrist who's really dedicated to regenerative therapies, non-surgical management, I would say was always the first plan of attack. And ultimately, if you hit a point where the imaging also corresponds with your levels of pain and functional limitation, then that is where you drive for more of a surgical procedure. But there needs to be that functional limitation, recreational limitation, and daily pain where you're actually driven to get a procedure, rather than just, hey, I'm seeing some pathology on an imaging, maybe this needs to be fixed, maybe not.
And I think that, to me, is, again, super logical, right? Like, if you've really exhausted all options and you've evaluated what this thing is causing you in terms of pain and mobility, as you said, I think functional and recreational, matched with the pathology, the actual reality of it, which brings me kind of, I think, to my last question, which might be the hardest. I'm curious to know how you see stress affect people, and whether that's workplace stress or family stress or financial stress or the stresses of life. Do you see that oftentimes that does manifest in physical pain, or like, is there any correlation there between stress and anything that you see on your end? And the reason that I ask is because it seems to me, at least when I wake up and I'm not in my best mood, my body doesn't feel as good as it does when I'm in my best mood, right? So I'm curious to know whether that's all up here or if there really is some truth to that.
Yeah. Well, coming from someone who's never experienced any stress in my life, that's a tough one to answer. I'm definitely kidding. Running any small business or it provides stress, but also you have personal stress, you have work-related stress. There's stress about the pain. Creates what we call a pain inflammatory cycle, which can be kind of initiated by stress. And so more stress, more pain, more inflammation, more pain, more stress. As far as the evidence behind that, stress, the stress hormone cortisol is we're always trying to research and correlate that with different responses physiologically in your body. What happens with other neurotransmitter releases with stress hormones, whether they're excitatory or inhibitory hormones. There's a lot that goes on as far as a neurochemical process within their body. But in terms of how can that affect your physiology, but how does that also affect your perception on how you're feeling? So there's a lot of different things, but going on there. But the bottom line is stress can be good and stress can be bad, but we have to find that happy medium to navigate it. But there has been significant correlation between a stress response and pain. And so that's definitely something to understand, and finding a way to deal with the psychological component of the stress and limit its physical manifestations is definitely a big part of the rehab. And when being in a treatment room as a physical therapist, one-on-one with a patient for an hour, we do both. I always see whenever I'm hiring a new physical therapist, I always say the most important thing is, well, there's a few important things, but it's not just your clinical expertise, right? It's your personality, your energy. How do you connect with the patient? Because there's such a profound psychological element to pain, injury, and recovery that you need to reduce those stress levels and work with the patient on the psychological side to also work on the physical. Yeah.
And I think that is, to me, I mean, you hit the nail on the head, especially when you talk about stress to inflammation response, and inflammation response creating pain, creating more stress, and it becoming a cycle that fills itself. It seems to be that is the only ubiquitous truth that I've found in any type of modality of healing, is that it all adds up. Every little step in a positive way matters. And even though there are setbacks, you have to continue with the positive things that are going to make you feel better, because that's the only way to get the momentum shifted back towards the positive, as away from the negative stuff we want to stay away from. So we've taken a lot of your time. I will include this also in the comments below on YouTube and on the website, but when people want to come see you, who I recommend everybody come see you at least once in their life, hopefully soon, how do they get a hold of you? How do they find you?
Sure. You can come see our website. It's equilibriumpt.com. Equilibrium stands for physical therapy, so it's equilibriumpt.com. You can always just shoot me an email. It's matt@equilibriumpt.com. And just reach out to me. Happy to respond to any questions. And would love to help out anywhere I could. This has been a fun experience. Also, just another way to reduce stress, maybe sitting up in a canopy in Costa Rica. I recommend that as well. So I'll hop on a flight soon. But no, this has been fun. I love being able to share information and thoughts. This has been a kind of fun conversation. The more we can get some of this information on wellness and preventative rehab and management out there, and creating healthy lifestyles for people is just always a passion. So that's nice.
Yeah, I think to me, that's the mission, right? Is I love talking with people like you who are true professionals, and in particular, people who are practicing every day, because that to me is like, to be an artist that never paints. If you're a painter, like, what do you really know about painting, right? But you're seeing real people in front of you every day, and we appreciate you making the time. And we'll make sure to post all of your contact information below. Thanks for making the time, Matt. We really appreciate it.
All right, David. Great. Well, enjoy it out there.
I will. Have a great day.
Take it easy.